So, non-visualization of stomach people with polyhydramnios. This is a common thing, and persistently small stomach with polyhydramnios. This is also when there is tracheostomy fistula, small tracheostomy fistula, small stomach would be very small, and polyhydramnios will be there. Sometimes stomach will be normally distended with polyhydramnios. This is the one that is very, very difficult to suspect and diagnose. And whenever we are seeing normally distended stomach, whenever we are seeing polyhydramnios in polyhydramnios and without any cause for obvious cause for polyhydramnios, maternal cause or obvious fetal cause for polyhydramnios, we should look for this pouch. So transient appearance of blind pouch in the fetal neck or upper chest. Then when we are demonstrating that, there is chance for esophageal atresia. So these are the common findings you have to suspect in a case of esophageal atresia. We will see one by one. So here the third gravida. Now it is 26 weeks. Previous scan at 14 weeks report as normal. 24 weeks report as very complex cardiac anomaly because the heart is seen in the midline. For that, they suspect some cardiac anomaly. And another scan report as absent stomach bubble. So now it is 26 weeks. You can see there is no stomach bubble. So non-visualization of stomach bubble. So you can see cardiac pulsation, stomach bubble not seen. And significant polyhydramnios is there. In the neck, we are able to see the pouch sign. So it is very difficult. We have to wait in the neck to for the appearance of pouch sign. So it's a transiently appearing only during swallowing. So we have to wait in the fetal neck to see the blind pouch. It's a pouch sign. And see the midline heart. Almost heart is in more towards right side. So in seeing this only, they committed this may be a cardiac anomaly. And close examination of the vertebral bodies, see the multiple vertebral anomalies in multiple levels. See, the alignment is not normal. So usually we are seeing this was previously this fine is reported as normal because you usually see the three lines. Usually vertebral anomaly will see there is some curvature abnormality, slight curvature abnormality. If you are seeing slight curvature abnormality, then only we will see. We will suspect vertebral anomaly. Here there is no significant curvature abnormality, but if you are concentrating on the vertebral body alone, definitely it is not in a line. So multiple level vertebral anomalies are there. So with this, we report as esophageal atresia with the multiple vertebral anomaly and midline heart probably due to right hypoplasia and persistent left ACVC also there. So since patient is a third gravida, she doesn't want to continue the pregnancy. Pregnancy was terminated. See, so ultrasound of the specimen. So very small stomach, completely collapsed stomach. Completely collapsed stomach. Heart seen in the midline more towards right side. So that's left ACVC turning into the coronary sinus. Everything is nicely demonstrated. Here we can see the vertebral anomaly. See the zigzag arrangement of vertebral bodies. So multiple block vertebra, hemivertebra at multiple level. So CT of the specimen shows, see the vertebral anomalies, and NG tube was passed through the nose and contrast was instilled into the pouch. You can nicely demonstrating the plain pouch. So this pouch is clearly demonstrated. And one more interesting finding in the CT is the hypertense content within the descending colon and rectum, sigmoid colon. So usually this appearance will be seen in anal rectum malformation. So by seeing this only, we see the anus. After that only, so it is anal rectum malformation. So with this, all these findings, we came to the diagnosis of VATR. So vertebral anomaly, anal rectum malformation, tracheostomy fistula. So this case is a type A vertebral, type A esophageal atresia. So type C is the commonest one. So proximal blind pouch, the distal esophagus communicating viscous communication with the trachea. This is the commonest one, almost 85%. Other things are rare. In this case, one interesting finding is at 14 weeks, the stomach bubble was nicely demonstrated. So on searching in the net, it was given. So gastric secretions may cause some distension of stomach in early weeks. Only after 20 weeks, it will be emptied due to peristalsis. After that, the stomach content will be mainly by swallowing. So in this case also, it is nicely demonstrated. The 14 week scan nicely demonstrating the It's a normal visualization of the stomach. So this point is learned from this case. So it's a water syndrome. So here, primary term pregnancy, is referred as esophageal atresia. Here we are able to see the very personally small stomach. Previous case it is non-visualization stomach. Here it is personally small stomach, polyhydramnios. And at the time we are not demonstrating the pouch also. Baby was delivered, vertebral anomaly also there. So the coiling of NG tube at this level. So in the esophageal pouch. And we are able to see the air within the stomach and bowel loops. It means it is communicating, lower end of esophagus is communicating with the trachea. That's why the air is entering into the stomach and bowel loops. So tracheal fistula is there. Sir, type C, esophageal atresia. Here, this is a more interesting case. Sorry. Primary, 35 weeks referred as polyhydramnios. So previous scan at 20 weeks reported as persistent reptile CC and echogenic intracardiac foci. For that, second opinion was taken from senior radiologist at 23 weeks. That also reported the same. No other abnormality at 23 weeks. And growth scan at 30 weeks shows polyhydramnios. No other finding at the time. And next scan, 34 weeks only, polyhydramnios. And that same doctor suspected something unusual. So she searched in the fetal neck, finding the transient appearance of plain pouch. So report as cori tracheostomy fistula. So these are the scans at 20 weeks, 23, 30 weeks. So everything you can see the well-distended stomach. So the well-distended stomach with polyhydramnios. So whenever we are seeing polyhydramnios, esophageal atresia should be ruled out. So here, so see the stomach, well-distended stomach, and we are able to see the plain pouch in the neck. So pouch sign and polyhydramnios. So baby was delivered and operated within 24 hours. But the surgeon told us the fistulous opening was very large one. So almost the size of the trachea. So there is a large tracheostomy fistula was demonstrated. It was operated, but baby can't survive. So sixth POD, baby expired. So you can see the coiling of NG tube at this level. After surgery, the NG tube is within the stomach.
But was it a large distal tracheoesophageal fistula, Jayaraman?
Yes, sir.
No, that's the reason why the stomach was so big.
So, yes, sir. Yes, sir.
So much distal. Okay.
Sometimes double atresia, esophageal plus tracheal duodenal atresia also possible when there is a large stomach. But in this case, there is no obvious duodenal atresia. The surgeon definitely told this a large fistula between the trachea and esophagus that almost the size of the trachea. He explained that fistulous communication.
So that's yes.
Yes, sir. It's also a type C esophageal atresia. Here, the stomach is now well distended. So this type C esophageal atresia. So polyhydramnios with the option or small stomach bubble, we can easily diagnose esophageal atresia. But polyhydramnios with well distended stomach bubble, it is very difficult to suspect esophageal atresia. So we should concentrate on the fetal neck to look for transient appearance of plain pouch. The only thing to say it's a chance for esophageal atresia. So we should think like that. So non-visualization of stomach bubble is always esophageal atresia? No. So whenever we are seeing non-visualization of stomach bubble or very personally small stomach, you should think of other causes also. Here, so non-visualization of stomach and other causes means most of the time it is physiological. We should wait for some time. So dynamic structures, we should not commit with single examination like stomach and bladder mainly. So most of the time bladder will be committed as over distended, stomach will be non-visualized like that. So you should correlate with the Likert mostly. So stomach is not non-visualized, not demonstrated. Definitely Likert should be increased if it is pathological. If Likert is normal, you should wait for some time to demonstrate the stomach. That is the rule. And dynamic structures should not be committed any abnormality in the dynamic structures, especially in stomach and bladder. So repeat examination is a must. Here also, if the stomach bubble is not visualized, you should wait for some time. Mostly it is physiological and other pathological causes are also there. In this case, it is a stomach bubble not visualized, polyhydramnios, but there is no fetal movements. See the position of the fetus. The flexed hip with the completely extended knees. So, so fetal echinacea deformation sequence. See the fetus. So specimen. So it's comparable with the ultrasound image. So fetal echinacea deformation sequence. In this case, persistently small stomach. So referred as non-oscillation stomach with the option upper limbs. So persistently small stomach, but both upper limbs are absent. So I missed this specimen. So it's a case of microgastria, limb reduction defects association. So small stomach may be microgastria and limb reduction defects association. So this is another case. So small stomach, persistently small stomach, bilateral option upper limbs, bilateral upper limbs option and right lower limb is absent. Only in the four limbs, only left lower limb is present. So it's a case of, again, microgastria, limb reduction defects association. So only left lower limb is present, other things are absent. It's a small stomach, so microgastria. So absent stomach and persistently small stomach. So we should look for other causes also. So now we are seeing a case of option of small stomach with polyandrous. We should check for fetal movements and any other limb deformity. That is also, then only we can come to a conclusion. So coming to duodenal atresia or stenosis. So duodenal atresia may be partial or complete. So complete atresia, easily we can diagnose. Partial means in partial also we can see double bowel appearance. Partial may be due to volvulus or annular pancreas or mucosal web within the lumen. So that may cause partial obstruction. So in that situation also we can demonstrate double bowel in the fetal abdomen. So it's a typical case, 36 weeks, referred as polyhydramnios. You can easily demonstrate double bubble sign. So communicating to each other. So whenever we are seeing the double bubble on each side of upper abdomen, we have to demonstrate the communication. Then only we can say it is a duodenal atresia, the polyhydramnios. So baby was delivered. So see the first stage is obviously duodenal atresia, but at the time the ultrasound was reported as normal. So I don't know why it is like this. And third day there is no air within the distal bowel loops. So surgery management was delayed. So on seventh day, baby died due to birth septicemia and low birth weight. So we can't save this baby. It's a easily correctable one, but in this case we missed this baby. And this is another case, typical double bowel second lavada term pregnancy. So double bowel appearance, we can see to and fro movement of fluid from stomach to duodenum, duodenum to stomach in color Doppler. So nicely demonstrated, and polyhydramnios was there. So baby was delivered, so we can see the double bowel. But second day we are able to see some amount of air within the distal small bowel loops also. So that means the obstruction is not complete. So some lumen is there through which the air is going into the distal bowel loops. So operated, so type 1 duodenal atresia. Type 1 means there is a continuity of wall, muscular wall, only the mucosal atresia. So through this some air is leaking into the distal lumen. Here type 2 is bilateral brain loops with connected by a fibrous cord. Here it is completely away from, two ends are completely away from each other. It is type 3. It was operated and doing well. Duodenal done. Here, a complex case is duodenal atresia. So limbs are abnormal. So right upper limb shows the forearm is deformed and vertebral anomaly is there. And polyhydramnios and cardiac anomaly was also there. So transposition of great arteries. So parallel orientation of great arteries. So again, fractal association. So this is the baby, see the upper limb. So radius is option, thumb is option, radial ray deformity, so vertebral defects, so duodenal atresia, and malrotation was also demonstrated. So SMA axis was altered, but there is no obvious volvulus could be demonstrated. So fractal association. This is a very interesting case. Elderly preemie, 40 years, married since 17 years. So hypothyroid, GDM, all complications are there. So referred for anomaly scan. So NT scan at 14 weeks was reported. All findings favoring aneuploidy, Down syndrome. Here, Manohar sir only did this scan. So NT increased tricuspid regurgitation was absent nasal bone, and biochemically also it is high risk for trisomy 21. So, but patient wants to continue the pregnancy because he wants to prove she is fertile. So, married since 17 years. So, patient wants to continue at 20 weeks. Anomaly scan. So, yeah, another finding. So, double bubble was demonstrated. So, there is no other abnormality. Brain, spine, everything normal. Heart is also normal. So, patient continuing the pregnancy. At 26 weeks also, double bubble demonstration, but liquor is not increasing. So, that is against bowel obstruction. But we are able to clearly demonstrating the double bubble. See, stomach and duodenum are clearly demonstrated. So, to and fro results also demonstrated within here. At 26 weeks, another finding is cardiac axis deviation. So, left axis deviation was demonstrated, but there is no obvious cardiac anomaly. At 33 weeks also, same findings, but liquor is decreasing. So, that is definitely against bowel atresia, but we don't know at the time, we don't know what is the diagnosis. So, mild TR was also demonstrated, tricuspid regurgitation. 36 weeks, liquor is still decreasing, but Doppler parameters are normal. So, baby was delivered. See the features. So, typical features of Downs. So, depressed nose, low tears, so everything, but baby passed meconium. So, see the color of the meconium. This means the bile is mixed with the distal bowel contents. So, in complete atresia, the baby will usually pass colorless meconium, so white meconium. Here it is normal colored meconium. That means there is no atresia. So, X-ray shows there is no double bubble. But in AN scan, we obviously demonstrated double bubble, but here there is no double bubble. So, but we are confident we are in our AN scan finding. So, we instill contrast through the NG tube. So, that shows double bubble. So, this is the stomach, this is the dilated duodenum. But delayed X-ray shows complete good emptying of stomach contents. That means there is no obstruction. So, with this, we came to the diagnosis of megaduodenum. So, congenital megaduodenum without obstruction. So, that's why there is double bubble, there is no polyhydramnios. From this case, we learned this finding. So, echo shows AST, PDA, moderate pulmonary hypertension, moderate TR, everything is there. And it's a typical case of Down syndrome, the congenital megaduodenum without obstruction. No major cardiac anomaly. 1 year follow-up was done at shows a delayed milestone. But there is no vomiting, no feeding difficulties. So, double bubble without polyhydramnios, we should think of congenital megaduodenum. If you are seeing double bubble, we should look for other features of trisomy 21. So, most of the time, duodenal atresia will be an important finding in Down syndrome. And left axis deviation of fetal heart may be present without any major cardiac anomaly. In this case, also, there is no significant cardiac anomaly. And this is more important. Patient expectation and acceptance are the prime factors when we are counseling the patient for to continue the pregnancy, for termination, like that. So, except in lethal anomalies. Lethal anomalies, there is no other way, we have to terminate. Other things, patients are the deciding factors. So, these are the mimics already I told. So, these are the mimics of duodenal atresia. So, this is the stomach, is the large gallbladder. So, we mimic like a double bubble. So, with this, you should not commit as a double bubble sign duodenal atresia. So, we have to demonstrate communication between the two bubbles. Here also is the stomach, this is the cold occult cyst mimicking as double bubble. So, coming to jejunal atresia. So, jejunal-ileal atresia share common, but in jejunal atresia, only stomach, duodenum, and some part of small bowels will be dilated. In ileal atresia, almost multiple bubbles will be there. So, let's see here. Here, you can see the dilated stomach. See? So, left side is the stomach and duodenum, and then this is the jejunum. So, here we can see polyhydramnios is there. No other major anomaly. Baby was delivered, so immediately operated. So, it's a type 1 small bowel atresia. So, there is a continuity of the muscular wall, only the mucosal atresia. Here also, this see the continuity, there is no mesenteric defect. There is no blind end. So it's continuous. So type 1 small bowel atresia. This case also very interesting one. So 36 years primary, 8 years infertility. Now 8 months after small bowel atresia. 20 weeks scan shows absolutely normal. So there is no abnormality, there is no dilated bowels, nothing is there. At 31 weeks, there is dilatation of stomach and duodenum with hyperperistalsis. So some DJ flexure seen on the right side, suspecting DJ midcut malrotation with obstruction at the DJ junction. So one report. Next day report was small atresia. So with this combination, so proximal jejunal atresia with malrotation is usually the finding in apical atresia. So here you can see the triple bowel polyhydramnios. You can see stomach, duodenum, and proximal jejunum dilated. So this midcut malrotation plus jejunal atresia is equal to apical atresia. Usually a formula. It is fitting into 2 or 3 cases. So here also you can see the to and fro movement of contents. So baby was delivered. So triple bowel appearance. So what we expected was correct. So this is a jejunal atresia with the distal small bowel loops are arranged in a coiled manner. So very short mesentery. The bowel loops are coiled around the mesenteric vessels. This is a apical appearance. See the colorless meconium. I already told. So whenever there is bile is not mixing with the distal bowel contents, the meconium will be colorless. So here also it is colorless meconium. So they are checking the patency of distal bowel loops. So there is no other atresia, only one atresia, jejunal atresia only. There is a distal bowel loops are pattern. So they did the surgery. Anastomosis was done. So this is the apple pill atresia. So it is mimic same as apple pill. That's why it is apple pill. So type 3B atresia. So they to 1 month of age, baby have severe respiratory infection and hypoxic changes. But at that time also, and delayed milestones was there for the baby. And CT at 1 year of age shows prominent lateral ventricles with the paucity of perineal white matter. So HA is equally. But 6 years, baby was almost normal. No profound mental retardation. So delayed milestones was there. So CT shows dilated stomach, duodenum, and proximal jejunum, but there is no obstruction. Baby is doing well. Now she is almost 14 years. So these are the types of small bowel atresia, jejunal atresia. Type 1 again. So mucosal atresia with wall is continuous. Here it is blind end with connected with the fibrosis. There is no mesenteric defect. Here it is mesenteric defect is there. So 3A, 3B. So there is mesenteric defect with the distal bowel loops arranged in a apical appearance. And type 4 is multiple atresias. So these two types have poor prognosis. This will have, if it is isolated, will have good prognosis. So this case also referred as evolving bowel abnormalities. Primary 30 weeks pregnancy. Previous scan at 14 weeks, 20 weeks were normal. At 28 weeks only, she noticed some dilated bowel loops. So evolving bowel abnormality, like it was reported. So here at 30 weeks, see the stomach, duodenum, and jejunum. So C loop of duodenal C loop is clearly demonstrated, dilated, and jejunum also dilated. So with this, and in this case, we are able to demonstrate the altered SMA axis. So malrotation was there. So jejunal dilatation, everything is nicely demonstrated. SMA axis also altered. You can see here. But there is no twisting was demonstrated at that time. So from the experience from the previous case, so it's again it is a proximal jejunal atresia plus midcut malrotation is equal to apical atresia. And follow at 32 weeks, we see some abnormal findings. See, whenever we are seeing atresia, the distal bowel loops should be collapsed. So here we are able to see some amount of fluid and thickened wall in the distal bowel loops. So something happened, we suspect. So it is not normal. So whenever there is atresia, distal small bowel loops will be collapsed without any fluid. Here we are seeing some amount of fluid and thickened wall like this. So now polyhydramnios is there. So baby was delivered. See the tool bubble. During delivery, the obstetrician told, "Sir, the liquor was meconium stained. You reported as bowel atresia. It is meconium stained liquor, sir, like that." So we are shocked. How it is possible? So we see the baby. See the right tube aspirate. So it is almost bilious aspirate. So we send. We saw the photo to the obstetrician. Sir, it's the same color, sir, liquor is. So it is not meconium stained, madam. It is only baby's vomitus. So bilious vomiting, that looks like meconium stain liquor in this case. So from this case only we learned this point. In the case of small atresia, if there is altered color of the liquor, it is not due to meconium, it is due to vomitus of the fetus. So it was operated unluckily. So it is again apicipal atresia, but it is going for volvulus and gangrene, complete gangrene of the small bowel loops. So that's why we are seeing some thickening and minimal fluid in the distal bowel loops. So complete gangrene of the small bowel loops. So everything was resected, only duodenum, proximal jejunum and distalmost ileum was there. So baby survived for 40 days without small bowel, so and expired. So it's also a apicipal atresia complicated by intrauterine volvulus and bowel gangrene. So coming to ileal atresia, so multiple bowel. See, almost entire fetal abdomen is filled with bowel loops, direct bowel loops with hyperperistalsis. So liquor is almost normal. So the atretic ileal end is clearly demonstrated in the right iliac fossa region. So whenever there is distal atresia, there is less chance for polyhydramnias. So swallowing will be present and intestinal absorption will be present. There is less chance for polyhydramnias, or polyhydramnias will appear later. So that is the rule. So more proximal atresia, more severe early appearance of more severe hydramnias. And whenever there is distal atresia, so liquor will be almost normal or minimal polyhydramnias will be there. So compared to urinary atresia and jejunal atresia, ileal atresia is more prone for intrauterine bowel perforation. So close follow-up is necessary. So that's why we suggested every 2 weeks follow-up. So at 34 weeks, see liquor is slightly increasing. So dilatation is increasing. But at 35 weeks, patient came with not able to feel fetal movements since morning, like that. So what we expected happened. So we are able to demonstrate, see the bowel loops, not that much distended now. We are able to see minimal free fluid within the peritoneal cavity, liquor is increasing. So it is intrauterine bowel perforation, ileal atresia, intrauterine bowel perforation is suspected. So immediately LSES was done. See the dilated bowel loops. Here also colorless meconium. So that means the bile is not mixing with the distal bowel contents. Ultrasound shows ascites with thick internal echoes, collapsed bowel loops. So baby was operated. Unluckily, again, it is gangrene. So it is ileal atresia going for volvulus, complete gangrene. So everything is resected, and baby died on the 10th POD. So here also intrauterine volvulus gangrene. So coming to this case, second gravida term pregnancy referred as ileal atresia. Previous baby died due to small bowel atresia. So previous history of bowel atresia is there. Previous baby also died. And now it is almost near term pregnancy. 38 weeks, grossly dilated bowel loops. Urine sphincter was normal, liquor is slightly increased. And see the content. So it is almost thick echogenic content. See the fluid. So it is almost comparable with what we see in the chocolate cyst, endometriotic cyst, like that, uniform internal echoes. So thick internal echoes. It's a poor prognostic sign. So baby was delivered. See the shining abdominal wall. So in newborn, this shining abdominal wall So poor prognosis. Usually have poor prognosis due to underlying peritonitis. Also dilated bowel loops, X-ray shows dilated bowel loops. So newborn abdominal distension with the shining abdominal wall, mostly poor prognosis. So ultrasound shows grossly dilated bowel loops with thick internal echoes, and distal iliac loops are collapsed. See, distal is collapsed with the echogenic content. Rectum is also collapsed. So it was operated. It's a complicated meconium. So multiple atresia and adhesions was there. So with the history of previous baby also died due to bowel atresia, this the chance for cystic fibrosis is more likely. This baby also died at 10th post-operative day. So another case, so 37 weeks, referred as dilated large bowel loops. So they sees a staff nurse. So baby first pregnancy normal, it's a 10 years old boy, and third baby died at 6 months of age. That was suspected cystic fibrosis. Now the fourth pregnancy. So only Manohar sir did the anomaly scan, but at the time everything was normal. But sir, with the previous history, sir suggested amnion exome sequencing to root cystic fibrosis. Even though he is a staff nurse, he didn't do anything. Everything is normal. Why we can do other tests like that? So, but at 31 weeks, there is polyhydramnios. At 34 weeks, so dilated bowel loops. They due to the echogenic content, they report as large bowel pathology. At 35 weeks, so dilated large bowel loops are referred. So now it is typical glossy dilated bowel loops with thick internal echoes. And in this case, we are able to demonstrate from the experience from the previous case. So we are able to demonstrate the collapsed iliac loops also. So collapsed iliac loops and also colon. So this is the left kidney, just handed to the left kidney, we are able to demonstrate the descending colon, and also right kidney, it's ascending colon we can demonstrate. So see the collapsed distal iliac loops. So collapsed iliac loops, completely collapsed colon and grossly dilated proximal iliojejunal loops with echogenic content. So mostly it is meconium complication. So on follow, so the dilatation increases, minimal ascites develop. We are able to demonstrate the twisting of mesentery. So due to some adhesions, so we are able to demonstrate the twisting of mesentery. See, twisting is clearly demonstrated. Mesenteric vessels twisting is clearly demonstrated. So again, sir, see the shining abdominal wall, grossly dilated bowel loops. Again, the same picture. So complicated meconium. In this case, the cystic fibrosis CFTR gene was genetically proved. So cystic fibrosis associated meconium and complication occurring bowel atresia. So whenever we are seeing small bowel atresia with echogenic content, it's a poor prognosis indicator. So here it is a plain ileal atresia, clear content. Here it is echogenic content. So another companion case as a newborn baby, 4 days baby. Previous baby also died due to bowel atresia, meconium. Here also dilated bowel loops. See the thick sticky meconium. So fetal imaging and also newborn imaging is almost parallel. So we should know the newborn pathology also. So thick sticky meconium, abdominal distension, shining abdominal wall. So that also meconium cystic fibrosis. In this case also crossly dilated bowel loops. See the collapsed colon. So right kidney, just anterior to right kidney, ascending colon, so descending colon. So everything is collapsed. So meconium. This baby also died at 20 days of life. So dilated tubular success within the fetal abdomen is always bowel obstruction. So no. So there is chance for other structures. So dilated bowel loops, dilated bowel loops without obstruction may also occur, and other system. So genitourinary system or ureter, dilated ureter may mimic like bowel loops. Should be very careful. Two different. Sorry. To differentiate between these. So here, so in this case, third gravida, you want to have a female baby, 31 weeks, referred as ileal atresia. At 22 weeks scan, it is reported as echogenic bowel loops. At 30 weeks, so dilated bowel loops are there. So they reported as ileal atresia. So see the appearance. Almost dilated bowel loops filling entire abdomen. So this is not ileal atresia because see the polygonal appearance of the dilated bowel loops. And also the fluid is demonstrated up to the rectum. So anal sphincter is clearly demonstrated. That means, so we are seeing fluid in the rectum means there is no proximal obstruction, and we are able to see the anal sphincter nicely means there is no anorectal malformation. So this is not due to obstruction. Some polyhydramnios was there. So it's see the dilated bowel loops having polygonal appearance. It's a turtle sign or honeycomb sign. So it's a typical appearance in congenital chloride diarrhea. So it's a case of congenital chloride diarrhea. So due to severe maternal distress, we aspirated therapeutic amniocentesis was done. Almost 1 liter was drained. See the color of the amniotic fluid. It is not normal. It's green is yellow in color. So baby was delivered. So see the diarrheal fluid. It's almost same with the our amniotic fluid. So in this case, the diarrheal fluid forms the amniotic fluid. In the previous case, the vomitus formed the amniotic fluid. So we should correlate. So with this, we came to diagnosis of congenital chloride diarrhea. So chloride supplement was started in this baby, but parents are very neglecting. They won't respond to the treatment. So at 3 months of age, baby came with this condition. So severe renal failure and expired. So in this case also, genetically proved. It's a chloride diarrhea. This gene, everything is proved. So see the appearance. Here it is congenital chloride diarrhea, it's a ileal atresia. In this, the dilated bowel loops, fluid-filled dilated bowel loops are polygonal appearance because there is no pressure within the bowel loops. That's why the adjacent bowel loops are compressing it and forming this polygonal appearance. Here, the bowel is under pressure. That's why it is convex shaped. So we should understand. Here, atresia is there. So the content is under pressure. It is causing convex shape. Here, there is no pressure inside the bowel. So adjacent bowel loops are compressing polygonal appearance. So this case also referred as abdominal cystic lesion with the dilated bowel loops. But this is a dilated bladder, stomach is not dilated. So another cystic structure adjacent to the kidney. So dilated ureters. So everything is there. So this is a bladder outlet obstruction with the dilated bilateral gross whiteout nephrosis with the perinephric urinoma. With this only they report as dilated bowel loops, but this is not bowel loops. So proved. So MCU source dilated ureter everything. So perinephric urinoma. So usually dilated bowel loops will have polyhydramnios, and dilated ureter usually will have oligohydramnios or anhydramnios. So we should, whenever we are seeing dilated tubular structure within the fetal abdomen, we should correlate with the lichen. So this also interesting case. At 7 months, referred as duodenatresia, patient was almost convinced for termination. But we are saying this would be shape of stomach. So we thought it would be a pyloric atresia, but liquor is not increased. We convince the patient to continue the pregnancy. So on follow-up, it found to be a duplication cyst. So shape of the cyst was like this, boomerang shaped. It's a duplication cyst. Another cyst was demonstrated in the adrenal region. So MRI, everything done, it was 2 cysts, but there is no bowel dilatation. There is no polyhydramnios. Postnatally, vertebral anomaly was also there. So vertebral anomaly and postnatal CT, everything confirmed the cyst in the large cyst and another cyst in the retroperitoneum. So everything was operated. It's found to be a ileal duplication cyst. So getting blood supply from the ileal mesentery. So it was resected, and the posterior retroperitoneal cyst was falsified. And histopathology confirmed it is a duplication cyst. This is a retroperitoneal cyst reported as neuroenteric cyst. So with this finding, it's a case of split notochord syndrome. So dilated tubular structure within the fetal abdomen. So no need to come to a conclusion of bowel atresia. So we should check all other structures, whether everything is normal or not. Then only we should come to a conclusion of dilated bowel loops. So now he is almost in 14 years doing well. So coming to conclusion, so other bowel complications are there. It's a large topic, meconium, peritonitis, meconium, pseudocysts, everything is there. So bowel atresias are evolving anomaly. So medically very, very important. So we should not commit why they are not committed in 20 weeks, not like that. So evolving anomaly is atresia and small bowel atresia, everything is evolving anomaly. 20 weeks anomalies can almost always normal. So bowel atresia is always associated with polyhydramnios. More proximal to atresia, early cross polyhydramnios occurs. Recurrent bowel atresia with echogenic content in small bowel, cystic fibrosis association should be considered a poor prognosis. You can't save the baby. And isolated bowel atresia usually have good prognosis. Bowel atresia should be operated within 24 hours. Starting oral feeds and delay in surgery are the major causes for morbidity and mortality. In our case also, in duodenal atresia, we lost the case. When we are seeing a case of bowel atresia, we should follow the case to know the final diagnosis. Then only we should be very confident. So when we are seeing this image, this is there. So it will survive or not, like that. So then only we can guide the next patient properly. And thank you so much, sir, for giving me this opportunity. I thank all the participants, known faces and unknown faces, for this meeting. And I thank my patients. So they taught me everything. So without them, because of them only, I am in front of you now. So thanks to all my patients. Thank you so much, sir.
Wow, what a plethora of cases you presented, Jayaraman. It was excellent collection of cases as well as the excellent follow-up that you have made with the post-natal pictures and the surgical pictures. Everything was excellent. So let us hear from the moderators.
Thank you, Jayaraman sir, as usual, for your excellent collection of cases and follow. So actually, what I love about your cases is the complete follow-up, the effort you take to follow them over years to know how they are doing. And actually, that is the main thing which is giving us confidence to tell that this is the diagnosis antenatally. And as correctly pointed out, antenatal diagnosis, though we cannot treat them antenatally, the immediate postnatal management will depend upon the diagnosis what we have made, as in the obstruction cases what you have told, so that they have to be kept nil per oral for the future management. Thank you, sir, for that excellent collection of cases.
Thank you, ma'am. Thank you, ma'am.
It was a very excellent presentation, sir.
Thanks, sir.
And actually, I have covered my part also. Most of the surgeries were demonstrated very nicely.
All pediatric surgeons are my friends, sir.
Okay, sir. Okay, sir. I got one or two small questions, Matu, sir. The first case, how was the distal fistula rolled out, sir, in the autopsy?
Which
Actually,
case,
contrast was given orally, which ended in a blind pouch.
Yes, sir. Yes, sir. That was aborted, sir. Aborted specimen.
Okay, how was the distal fistula ruled out, sir? Because it opens up only when.
I can't rule out, sir. It's waiting for autopsy. I will tell him.
Okay,
It is in formalin, sir.
Yes, sir. And similarly, for huge fistulas, when we encounter distal fistula, sometimes we may have to open up to ligate the fistula to prevent gastric perforation. That was nicely pointed out by you, sir. In one case where there was a gross gastric dilatation.
Yes, sir.
And one more thing that I want to add up on you said there was a meconium staining ileus, sir. Most of the times passage of meconium does not rule out ileal atresia, sir, because ileal atresia usually happens only in the late second or third trimester, by which time some meconium could have passed beyond the atretic segment. It's usually because of the vascular accident that happens late in the pregnancy.
Okay, sir.
And most of our ileal atresia patients pass normal meconium.
Okay, sir.
And that doesn't rule out ileal atresia, sir.
Okay, sir.
That's one thing I just want to add
cases,
over there.
3 or 4 cases I observed this. That's why I told, sir.
Yes, sir, because the same problem we encountered from the obstetrician.
Oh.
You said it's ileal atresia, but I have seen meconium in the amniotic fluid. How can you say it's an ileal atresia? This was the explanation actually. It usually happens very late in the second and third trimester. And meconium could have passed beyond that atretic segment even before that atresia has happened.
Okay.
That is possible explanation for that, sir. Anyway, thanks a lot for a very good presentation, sir.
Thanks, sir. Thanks, sir.
Today I learned a sign called a stored sign. I think most of the listeners also would have learned that sign, where the congenital chloride diarrhea, how it presents like the compressed bowel loops producing a appearance of a toad.
Polygonal.
Yeah, polygonal appearance.
turtle sign or cuneiforms.
This is a new thing which you have taught us today.
You only taught us that calcium chloride areas are very cases.
Thank you. Thank you. And I think many participants would have benefited by your exposition. Thank you very much. And we would
Thanks.
like to have future presentations from you like this.
Thanks, sir.
So let's move on to the next speaker from KMCH Coimbatore. That is Dr. Ravindra Kashyap, who is a brilliant radiologist, who is going to talk to us on anorectal malformations and their antenatal diagnosis and pitfalls. Yes.
Is my slide visible, sir?
Yes, your slide. So you can switch on your video also, Ravindra.
Sir, my internet connection is little unstable, sir. So at present, I'll switch off my video,
Then
sir.
you can proceed without your video.
Yes. Thank you, sir. Thank you so much for the kind introduction. At this outset, I would like to thank Dr. Manohar, sir, for giving me this opportunity. It becomes little challenging to present after Jayaraman sir's lecture. So for the next half an hour, I will be talking about the prenatal diagnosis of anorectal malformations. Anorectal malformations are a complex group of congenital anomalies involving the distal anus and the rectum, as well as involving the urinary and genital tracts commonly. The prevalence is around 1 per 5,000 live births with a slight male preponderance, and it is a spectrum of abnormalities. It ranges from mild anal anomalies to complex cloacal malformations. Let us briefly see the embryological aspect of the distal anus formation to understand the pathology better. At around 5 to 7 weeks of gestation, there is a common channel which combines the urogenital tract and the hindgut, which is called the cloaca, and it is covered by the cloacal membrane. And during development, the urorectal septum or the mesoderm develops in a craniocaudal direction, and while it develops, it separates the urogenital tract anteriorly, which forms the future urogenital tract, and posteriorly the future hindgut develops and it separates from the cloaca. And at the level of the perineum, the membrane covering the distal hindgut is the anal membrane, and the covering of the urogenital sinus is called the urogenital membrane. And later in gestation, these two membranes will rupture to form the separate openings of the urogenital tract system and the hindgut separately. Now, the anorectal malformations are broadly classified into the low ARM, which occur below the level of the pubococcygeal line, and high anorectal malformations, which occur above the level of the pubococcygeal line. Low anorectal malformations can occur without fistulas at the level of the anus in the form of imperforate anus and anal stenosis. And whenever there is an abnormal fistulous communication of the rectum with the perineal structures, then we call it differently as rectoperineal, rectovestibular, and rectoscrotal fistulas in male and female patients, respectively. In a case of high ARM, there can be a communication or it can occur without a fistulous communication. When there is no fistulous communication, it is considered as an isolated anal atresia. And when there is communication, in the males, it can be in the form of a rectourinary fistula, and it can occur at the level of the urethra or the bladder neck. And in the female, a common channel can be formed between the urogenital system and the hindgut, where it is called cloacal malformation. Out of all these abnormalities, the imperforate anus and anal stenosis are very difficult or close to impossible to diagnose in the prenatal life. But whereas let us see how to diagnose the other abnormalities with some amount of confidence. Now, in the earlier days, the anorectal malformation was suspected in a case of a fetal bowel dilatation only. But this had its own problems because the range of a normal bowel loop caliber, it had a wide range. Therefore, it was difficult to differentiate physiological dilatation from pathological dilatation. And therefore, they came up with the direct visualization of the fetal anus. Now, the fetal anus, as explained by Jayaraman sir, is the visualization of the anal canal at the level of the fetal perineum, and it is called the target sign or the perianal muscular complex. It is seen as a well-defined, rounded, echogenic structure in between, in the center, surrounded by the hypoechoic muscular layer. And it is confidently seen from starting from 17 to 18 weeks of gestation, and it is difficult to see before 17 weeks of gestation. And in the third trimester, it becomes very conspicuous because of the decrease in the central echogenic mucosa and increase in the surrounding muscular layer and increase in the surrounding perineal fat. Therefore, the target sign becomes more conspicuous in the third trimester. Now, what is the method to visualize the fetal anus? We need to do an axial sweep from the level of the fetal bladder in the pelvis and move on to the perineum. And below we must make sure that we are below the level of the ischial spine. So this is at the level of the ischial spine. We must make sure that we are well below the level of the ischial spine so that we are focusing on the perineum. And in the perineum, by doing a tangential scan in between the two hypoechoic gluteal muscles on either side, we see a central line that is interrupted by a rounded structure, which is the target sign, and that is how you identify the perianal muscular complex. In addition to the tangential axial view to visualize the PAMC, we have what is called the transperineal or the infracoccygeal view to view the fetal pelvic structures better. Now, this view is obtained in a mid-sagittal section in the fetal prone lie position. And when the transducer is placed just at the level and below the level of the fetal sacrum, we can visualize the pelvic structures in both male and female fetuses as seen here. This is helpful to assess the relationship of the anal canal with the other pelvic structures and also to look for or trace the anal canal in cases of low ARM to find out fistulous communications. Now, what are the imaging features of anorectal malformation on ultrasound? The first and the foremost sign would be the inability to demonstrate the normal anal dimple or the target sign. As seen in this clip, we can see that the echogenic line is uninterrupted and we do not see the target sign at the expected location. And the secondary sign will be a sausage-shaped blind-ending distended bowel loop in the pelvis with no communication to the perineum. The additional features that we will be able to see in some cases are enterolithiasis, which is nothing but intraluminal calcifications, previously thought to be only because of fistulous communication of urinary tract with the rectum, because of the alkaline urine combining with the meconium causing change of pH and precipitation of calcium. But recently it has been found to be seen in cases of prolonged stasis of meconium also. Therefore, it is not specific for a urorectal fistula. The genitourinary tract anomalies are commonly associated with ARM. They can occur in the form of multicystic dysplastic kidneys, ectopic kidneys, hydroureteronephrosis because of distal obstructions. And in the bladder, it can be in the form of a small volume bladder because of presence of fistulous communication. The bladder can get decompressed into the complaint structure, which is commonly the vagina in the female fetuses. On the other hand, distended bladder, and when the distension becomes extreme, abnormal shape of bladder can occur with lower urinary tract obstructions, which are common in these cases. Now, on the other end of the spectrum, we have the cloacal malformation, which is an extreme condition where there is a common channel collecting the urinary tract, the genital tract, and the hindgut. And commonly, the secretions from all these structures will get pooled in the vagina, and the vagina gets distended because of distal obstruction. And this will present in the form of hydrocolpus. And the hydrocolpus will be seen in the form of a unilocular or septated retrovesical pelvic cystic mass. It can have fluid sediment levels, and this is how we see the hydrocolpus. When commonly, it can be associated with a vertical vaginal septum as seen in this case. In that case, it appears bilobed. When the distension becomes severe, then this accumulated fluid can spill through the fallopian tubes inside the peritoneal cavity, where it can present in the form of echogenic ascites. Remember, cloacal malformations are almost always seen in female fetuses. The other common association with the ARM or cloacal malformation is the ambiguous genitalia, because the external genitalia has a similar embryological origin and it occurs at around the same time as that of the anal canal. Therefore, severe disruption in this region can result in abnormality in the genitalia formation, and it can occur in the form of ambiguous genitalia. This is one of the rare cases we saw in a case of a low ARM, where there was both the male and female type of external genitalia were present. And this is called a duplication of the external genitalia. And this is the picture of the abortus. And these were the prenatal ultrasound pictures, where you can see the female labia, appearance of the labia, as well as a phallus-like structure in the fetal perineum. And this clip shows a severe hypospadias associated in a case of anal atresia. Now, how do we diagnose an anorectal malformation based on an abnormal PAMC? The PAMC can be either absent, small size, non-visualized mucosa can be present, or it can be in the form of altered location. All these are considered as abnormal PAMC. The next step would be to look for a tract coming from the rectum, joining the scrotum in a male, or a vestibule or perineum. Vestibule in the case of a female fetus. If this tract is seen, then we know we are dealing with a low ARM. This can be seen in the infracoccygeal or the transperineal window. And if the tract is not seen, then high anorectal malformation is more likely. Now, in a case of high ARM, the next step would be to look at the external genitalia. In a male fetus, if you see dilated bowel or a non-dilated bowel with enterolithiasis, then rectourinary fistula is more likely. If it is absent, then we are most likely dealing with an isolated anal atresia. In both female fetuses and fetuses with ambiguous genitalia, the presence of any of these features, enterolithiasis or a large pelvic cyst, ascites, HUN, altered shape of bladder, will indicate the presence of a cloacal malformation. Let us see some cases. This is the first case presented at 20 weeks of gestation for routine anomaly scan. Here you can see the PAMC is visualized, but it is visualized in a much anterior location than the expected location. This was at the level of the fetal perineum. We can see the vestibule here, and the anal opening is closely associated with the posterior aspect of the vestibule. And this is the control case, where you can see the vestibule is, the anal opening is away from the vestibule. Now, next we went on to do the transperineal window to look for the low ARM. Here we can clearly see that the anal canal is parallel to the urinary tract. But whereas in a control case in the transperineal window, we can see the rectum angulated anteriorly, forming a recto-anal angle, but the distal portion of the anus is always angulated posteriorly with respect to the urogenital tract. This is how we see in a normal fetus, but in our case, the anal canal was directed anteriorly and closely parallel to the urogenital system. Therefore, this is a case of a suspected rectovestibular fistula because of the close association of the target sign with the external genitalia. A useful tip to remember is, in a case of a female fetus, the entire external genitalia and the target sign is usually not seen in the same section. Usually, we will require different sections, different angulations to see the entire aspect of the female external genitalia and the anal canal. When they are seen in the same section, then you have to suspect a low ARM. And always go back to the transperineal window to look for the anteriorly angulated or presence of the anal tract, the presence of the anal mucosa coursing anteriorly and parallel to the urogenital tract. And this is the 3D rendering showing the opening of the anal canal closely in the posterior aspect of the vestibule. And this pregnancy was continued, and this is the postnatal image showing the fistulous opening in the posterior aspect of the vestibule. And this is the anal dimple, the expected location of the anal canal, but here the anal opening was not seen. And this is an image from a normal female newborn for comparison. This is the second case. This was a gravida 2 presented at 17 weeks of gestation. Here you can see an external genitalia is of the male type. You can see the phallus and the scrotum. And here the anal opening was seen in a much anterior location than the expected location. Somewhere here is the expected location of the target sign, but it was present more anteriorly. Again, the entire external genitalia and the anal canal is not seen usually in the same section. In addition, this patient also, this fetus also had bilateral small sized kidneys, and there was persistent left SVC. You can see the fourth vessel here in the 3-vessel view, and there was persistent non-visualization of the gallbladder. This was at 20 weeks of gestation. We followed this case at 17 weeks, and this was the picture at 20 weeks of gestation. And this is the clip of the transperineal infracoccygeal window showing the anteriorly angulated anal canal. Whereas normally we see this slight posterior angulation of the anal canal that was absent in our case. It was anteriorly angulated. This, because of the multiple anomalies, the couple opted for termination of pregnancy. And this is the picture of the abortus showing the anal opening close to the scrotum. Now, this is a picture of a normal male newborn showing the relationship of the anal opening with the scrotum and the coccyx. We have what is called the anal position index. When you calculate the distance from the posterior aspect of the scrotum to the anal canal and the distance of scrotum to the coccyx and divide both these values, normally the anal opening is slightly more posterior than the midpoint between the scrotum and the coccyx. This anal position index is normally around 0.55 to 0.56. But in our case, the anal opening was seen well anterior to and close to the scrotum than the coccyx. Therefore, this is an anteriorly placed anal opening, and this is a case of a low anorectal malformation. Moving on to the third case. In the first trimester NT scan, we saw a fluid-filled cyst in the pelvis posterior to the bladder. Here you can see the bladder anteriorly, and posterior to the bladder, there was a fluid-filled cyst. And this cyst extended into the lower abdomen. So we followed this case at 20 weeks. In 20 weeks of gestation, the target sign or the perianal muscular complex was not seen. And this is the coronal and the sagittal clips showing the blind ending sausage-shaped distended bowel loop in the pelvis, representing the dilated rectum. The patient opted for termination of pregnancy. This is the picture of the abortus showing the absent anal opening. And this is the CT of the abortus showing the blind ending bowel loop, and the ultrasound of the abortus again showing the blind ending bowel loop in the pelvis. And the autopsy confirmed the absence of any fistulous opening. And this was the blind ending bowel loop termination. This is the bowel loop on histopathology. And here you can see the vaginal canal extending up to the perineum. So this is a case of a high anorectal malformation without fistula. Case 4. Okay. Case 4, 18 weeks of gestation referred as megacystis and posterior urethral valve. When the scan was Am I audible?
Your voice is breaking, Ravinder.
Ma'am, now?
Yeah, now it is okay.
Okay. At 18 weeks of gestation, this was referred as megacystis. A scan was repeated here, showed an over-distended enlarged bladder with abnormal shape. There was bilateral echogenic kidneys, and the external genitalia showed an ambiguous genitalia with a enlarged phallus-like structure, but labia was also seen, and there was presence of enterolithiasis with intraluminal calcifications. The patient opted for termination, and this is the CT of the abortus confirming the presence of enterolithiasis, and this enlarged phallus-like structure turned out to be clitoromegaly. And on autopsy, we found a large distended pelvic cystic mass, and the blind ending sigmoid colon was attached to this cyst. In the posterior aspect of the cyst, we saw a small uterus-like structure along with fallopian tube, and a gonadal organ was seen, and this turned out to be an ovarian tissue on histopathology. Hence, the findings conform to the presence of a large pelvic cyst with blind ending bowel loop. The presence of female genital structures confirms the presence of a cloacal malformation. This is case 5, referred for cross-fused ectopic kidneys. The scan done here showed the absent perianal muscular complex. The sagittal section showed the abnormal spine with absent lower lumbar elements, and the entire sacral spine was absent. And there was closely opposed iliac wings, and there was cross-fused ectopic kidneys. Now the presence of this hypoechoic structure in the fetal perineum likely corresponds to the opposed gluteal muscles with absent anal opening. So this is a case of an anorectal malformation with caudal regression syndrome and cross-fused ectopic kidneys. This is the next case at 23 weeks referred for diastematomyelia in the sacral region. Ultrasound done showed a low-lying conus medullaris. Here you can see that the conus was extending well below the lumbar vertebra and extending up to the upper sacral elements. And it was a male type of external genitalia. The target sign PAMC was not satisfactory. It was abnormal with absent muscular component. And we proceeded with fetal MRI. This is the T2 weighted sagittal section of the fetal abdomen, showing the T2 hypointense material within the rectum. Meconium appears hyperintense on T1 and hypointense on T2. Here you can see that the T2 hypointensity of the meconium in the rectum does not reach up to the perineum. It stops at the level of the bladder neck. And this is an SE-EPA sequence to evaluate the bony structures on fetal MRI. Here you can see that these three represent the ossification centers of the sacral vertebra. Here you can see that the distance between the sacral vertebral elements is increased on this side, indicating the presence of a hemisacral abnormality. On screening the mother with on fetal MRI, we saw that the mother had a large multiloculated cystic lesion in the presacral region. And there was also a hemisacral defect in the mother. The mother also gave history of surgery for anorectal malformation in childhood. So this is the hemisacral defect with a large presacral multiloculated cyst in the mother, along with history of surgery for anorectal malformation in the childhood for the mother. So combining all the findings, this is a case of a Curarino triad. That is, it is a triad of anorectal malformation, sacrococcygeal defect, and presacral mass. This is an autosomal dominant inherited condition. So this is one of the rare causes of inherited cause of anorectal malformation. So a clinical flowchart for an algorithm for the non-visualization of PAMC would be as follows. First, you have to look at the timing of the scan, that is the gestational age. Before 17 to 18 weeks of gestation, the PAMC is not visualized. It can be seen only after 18 to 20 weeks of gestation. Then you have to see whether the technique has been properly followed. We have to take a tangential section at the level of the fetal perineum, below the level of ischial spine. Above the level of ischial spine, we can mistake the rectum for the anal canal. Therefore, we have to make sure our technique is proper. Even then, if the PAMC is not visualized, then we have to search for an abnormal location of PAMC. If it is present, then we have to suspect a low anorectal malformation. If there is the location is abnormal location is also it's not visible, then you have to look for dilated bowel loop, to look for high anorectal malformation. And in the pelvis, you have to search for an associated pelvic cyst, which can give a clue to a cloacal malformation. Then the next step would be to evaluate the external genitalia and search for associated anomalies. Fetal MRI also has some role. On MRI, in the T1, the meconium appears hyperintense, and on T2, meconium appears hypointense. So MRI is useful to search for the bowel loop, the termination of the bowel loop if it is inconclusive on ultrasound, and to know for associated anomalies. This is a case of a cloacal malformation where you can see the blind ending bowel loop attached to the bladder, and here the T2 hypointensity has reduced signal because of the mixing of the urine with the meconium. And here on T1 weighted images, we can see the blind ending T1 hyperintense meconium of the distal blind ending bowel loop. Can we diagnose anorectal malformation or at least suspect in the first trimester? Yes, it is possible, because anorectal malformations can present with dilated bowel loops in the first trimester. Because the anal development is not complete till about the end of first trimester, it can present as dilated fluid-filled bowel in the pelvis and the lower abdomen in the first trimester. And typically, this dilatation will disappear in the mid-trimester because the bowel starts reabsorbing the fluid. And it may reappear in later gestation because the anal sphincter contractions will typically start at about 24 to 26 weeks of gestation, at which time the fluid accumulation can reappear in the bowel loops. There are certain syndromic associations with anorectal malformations like Vactral, caudal regression, OEIS complex, and the Klippel-Feil syndrome. So whenever you find an anorectal malformation, we have to search for these associated anomalies to look for syndromic association. The prognosis in isolated cases of ARM is usually good, and with associated anomalies, it depends on the severity of these anomalies. To summarize, target your target sign in all cases of anomaly scan and carefully search for the PAMC. Have a high degree of suspicion, and pattern recognition by associated features is important to identify the subtype of anorectal malformation. And a postnatal follow-up or perinatal pathology in cases of untoward outcome will increase the confidence of reporting, and adequate counseling has to be done with a multidisciplinary team involving the pediatric surgery. Thank you all for the patient listening.
Excellent presentation, Dr. Ravindra. You made it very clear, and difference between the low anorectal malformation and the higher anorectal malformation, the anteriorly extending anal sphincter, all those things were nicely explained. But still, I think pediatric surgeons will definitely agree with me that most of the low rectal anorectal malformations are missed antenatally. Yes. Isn't it, Dr.
Thank you, sir.
Vijay?
I will be very happy if it is identified in all the cases, sir.
Yes, yes. So most of the cases what you see in your postnatal practice, I think would be missed antenatally.
Yes. They are even diagnosed even days after the child is born, sir, coming with a huge abdominal distension in a very bad shape. That's one thing that we usually don't get to see in antenatal scans routinely.
What is the percentage of the anorectal malformations what you see in your postnatal practice being missed in the antenatal scans?
Only less than 20 to 30% cases are diagnosed, I believe, sir.
Why? That's correct figure, I think. Yes. And we can go to the questions that are in the chat box.
Sir, on
Jayaraman has got a question from Dr. Preeta Ashok. Sir, in a fetus with persistently small non-visualized stomach and polyhydramnias, if you are able to clearly visualize the esophagus in the cervical and thoracic region, can esophageal atresia be confidently ruled out, or does the possibility of esophageal atresia with distal tracheoesophageal still remain? Tracheoesophageal fistula still remain. How do you recommend the follow-up in such cases? That is, what she means is that in a case where there is a small stomach, you are able to see the triple line of the esophagus, both in the thorax and also in the cervical region. Would you be able to confidently rule out esophageal atresia, or still there is a possibility that there could be an atresia? And how would you recommend the follow-up in such cases?
non-visualization stomach with they are able to demonstrate the normal.
They are able to demonstrate the normal esophagus.
Normal collapsed esophagus.
Collapsed esophagus as a triple line in the thorax as well as in the upper, going into the upper abdomen.
It is very difficult to demonstrate the entire esophagus.
It's not possible to demonstrate the entire esophagus in a line, but
Yes,
it may be seen in parts.
We can see it in portions.
Yes.
But I think it is not possible to demonstrate the esophagus in all patients. It depends on the habitus of the patient also. When they are very thin and we have a good position, in few cases we are indeed able to trace the entire esophagus as that three hyperechoic lines. And unless there is not much fluid, I mean, if we can see fluid in the communication, maybe we can tell there is a fistula, but we are not confident in ruling out completely that there is no fistula. And of course, the pouch can be identified only in about 40% of the cases, not in all cases. So whenever you have a small stomach and polyhydramnias, again, we will have to suspect, and we have to at least raise the suspicion so that the baby has a postnatal evaluation by the surgeon to rule out these things.
We have to first evaluate after 24 to 48 hours and still see whether the persistent small stomach is persisting. And if it is still persisting, raise the possibility of esophageal atresia and make a serial follow-up. If they are willing to continue with the pregnancy, make a serial follow-up at 2-weekly intervals.
Yes, sir. With the setting of polyhydramnias, it is very difficult to demonstrate the dilated esophagus itself, I think.
Okay,
So,
then
esophagus it is difficult.
there is another question by Dr. Vijay Kumar. He asks you in the third trimester, what is the criteria to tell dilated bowel loops, sir? Sometimes we may see some prominent colonic loops near term. What is the criteria for small bowel loops and what is the criteria for large bowel dilatation, to call it as a dilatation? Small bowel loops, I think it's 7 millimeters.
Yes,
and large bowel loops,
sir, actually,
18 to 20 millimeters.
This one thing is a common concern because many a times people see meconium filled large bowel loops during the term and they call it as dilated bowel loop. Yes. So that is one case, one scenario what we commonly get for second opinion. And sometimes in axial section also they will see the rectum behind the bladder and they will call it as a cyst. And that is also another thing that I think that is what they're asking. What we say is more than 18 millimeters abnormal in the third trimester, but up to, I mean, it's a wide range like what Ravindra showed, up to 23 can still be normal. And we have seen sometimes even up to 25 normal bowel loops filled with meconium. Only thing is we have to trace the entire loop and if it is peripherally placed and if it is uniformly, if it has a uniform size and it is filled with hypoechoic material, that is how the meconium appears during the term, then we do term it as normal. And whenever you are able to demonstrate the communication of the rectum with the anal canal and demonstrate PMC, most of the time it is normal. We have had few scenarios where it looked like a blind ending pouch, but we could demonstrate the anal canal. So if we see the rectum, the anal canal, and the PAMC, most of the time it is normal.
So there is a doubt for Dr. Chellappan whether it is an ischial tuberosity or whether it is an ischial spine. What?
So that is ischial tuberosity, sir. It should be for the PAMC, it should be at the level distal caudal to the ischial tuberosity.
Okay. And Meghana Katkar wants you to repeat the ARM algorithm again. Show the low ARM algorithm again. That's your last slide.
Yes.
I think that will be useful for others also. You can show it again. Previous one.
I think this one.
Yes. So you can explain it.
Yes, sir. When first you see the non-visualized PAMC, first you have to see whether you're seeing a scan after 18 to 20 weeks. Make sure that it is a mid-trimester scan and make sure the technique is proper. Then search for abnormal locations of PMC. It can be abnormally anteriorly located. So first you have to search for an abnormal anteriorly located or a location close to the external genitalia. If it is not there, then the next step will be to evaluate the bowel. You have to look for a distal blind ending bowel loop. That will give a clue for an high ARM. If that is also not, that is seen, and then the next step would be to evaluate the fetal pelvis to look for an abnormal cyst in the pelvis. That will give a clue for cloacal malformation. And again, we have to see the external genitalia and look for associated anomalies. The KUB has to be screened.
Okay, that was a nice explanation. And what is the normal distance between the vestibule and PMC, and how to suspect it is low placed on ultrasound?
So there are no prenatal studies to suggest an objective measurement between the vestibule and the anus. That is not yet available. It is only a subjective assessment. That is why a useful tip is the entire external genitalia, and for a complete PAMC, usually we do not see in a single section. Usually for the external genitalia, an anterior angulation will be required, and for the PAMC, a slight posterior angulation will be required. If you see both in the same section, and if it is very much anteriorly placed, then you have to suspect a low ARM. But there are no studies to objectively assess the distance of the anal canal from the anus from the vestibule in the prenatal life.
That's purely subjective.
Yes.
Okay. And someone has asked, what is the criteria for dilated stomach or when to suspect pyloric atresia? Jayaraman, when to suspect pyloric atresia?
So grossly dilated stomach with polyhydramnios. Whenever there is proximal atresia, early severe polyhydramnios will be there.
Without
And
a typical
no fluid in
dilated duodenum, if the stomach alone is dilated,
yes, sir.
without a classical double bubble.
It's very rare. I never seen a case of pyloric atresia. So definitely, if there is a complete atresia, distal bowel loops will be lack of fluid. So you can't see any fluid in the distal bowel loop, and severe polyhydramnios will be there.
How to proceed in further in case of a single dilated bowel loop? Single dilated bowel loop. How to proceed further?
Single dilated bowel loops. Only NDT called focal segmental dilatation, I think. In one case, I suspected that, but on follow-up scan, it resolved.
Most of the time it disappears.
Yes, madam.
And if it can come only in the case of closed loop obstruction, where a single loop can be dilated.
Usually it's due to inspissated meconium, which is causing the transient obstruction, and it can resolve by itself. Okay. And we have to suggest a torch panel in such cases to rule out CME infection. Any specific criteria for microgastria?
The chart is available, sir. Gestational age-based chart is available.
Yes, chart is available. And there are no more further questions. And
One question, sir, to Ravinder, sir. So you showed one case on dilated segment cystic lesion communicating with the bowel. Is it congenital pouch colon possible, sir?
Sir, that actually
So
on
that
Autopsy findings you showed. So you described
that
everything like congenital pouch colon like that. That's why I'm asking. It's possible, sir.
there was no anal opening in that case.
Yes, madam.
Actually, and it did not
Communicating
have
with the-
rectum also, sir. Rectum anal canal was not there. And the cystic lesion, they could find out urothelium on the histopathology. So they
Oh.
ruled out pouch colon.
Okay, madam.
So it
But
was
description
they demonstrated a few urothelial cells in the wall
Okay.
of that cyst.
what investigations we have to do for an echogenic bowel loop? Echogenic bowel loop.
So major dilemma. And in our place, we do extensively evaluate all the echogenic bowel loops. And the first and the foremost thing is to rule out artificial, that's the false positive things. So whenever you use a high frequency probe, most of the bowel loops appear echogenic. So turn out to a low frequency probe. Be sure that it is not an artifact. And whenever you're seeing an echogenic bowel loop, the things are mainly for infection and CFTR gene. So we'll have to go with the high resolution microarray, torch PCR, and a karyotyping is what we follow.
Yeah. Karyotyping for trisomy 21 also. Yes. I don't find any more questions. Dr. Vijay Anand, do you want to share some of your pediatric surgery screens?
Sure, sir.
Yeah, please.
It's not a very big presentation, just a 5-minute presentation.
Yes. We'll
And
be
just-
happy. We'll be happy with your disposition. Yes. Please go ahead and share your screen. You do you find a share option? Yes. Yes. Your screen is seen. Your screen is seen. You can go full screen.
Thanks a lot for this very big opportunity. Thanks to Manohar sir and also the entire Society of Fetal Medicine. This presentation is a very short presentation, which I'd like to add some color to the beautiful black and white portrait that was created by the previous two speakers. I'll not be going too much into the surgical aspects. Usually, whenever there is a surgical call for me, the first thing that I'll be asking whether it is a hydronephrosis, abdomen distension, what is the antenatal finding? But there is one condition where we are more concerned about the sex, whether it is a male child or a female child. That is anorectal anomaly, because 99% of the female will have a fistula somewhere outside, which is draining the meconium. So they may not be needing immediate surgical attention. It can either be a anovestibular fistula, as we can see over here, or a vulvar fistula or anterior perineal fistula. All these things will drain off the meconium efficiently till around 6 months of age, when the child is started on weaning. So by that age, a single stage correction can be done. There's no need to go for a colostomy or a diversion. But very rarely there can be a rectovestibular or a rectoperineal fistulas, which may need diversion. Whereas in male, 90% of them will have a fistula into the bladder and will be an intermediate and high anomaly. Very few mimicking the female low anomalies will be present, where we can be able to make out by a beautiful cry impulse that can be made clinically when the child is crying, or there can be a small fistula to the skin with a cry impulse. A failed fistula formation, as in these cases, there's a small meconium pearl that is seen over here, and there can be a fistula equivalent to females. In all these cases, what we need to do is a simple anoplasty. Just open the perineum and do a primary anoplasty, which is adequate enough to let the biggest dilators inside. And these people usually do very well because they've got very good sphincters. Only when this thing fails, we'll think about high and intermediate anomaly. As our senior teachers, Dr. Ravi Kumar sir from Coimbatore, probably Ravinder will be knowing him. He usually teaches us whenever the child has got meconium in urine, straight away go for a colostomy. It's going to be a fistula into the bladder or fistula into the urethra, which is going to be an intermediate or high anomaly. Only whenever there is no meconium in urine, then we go for invertogram or cross-prone table lateral view. As he has already mentioned, either it can be, this is a very typical low anomaly where the loop is seen well below the eye line, whereas here it is an intermediate anomaly in between the PC and eye line, which marks the pelvic diaphragm. In all these cases, we usually go for a colostomy. And this is the typical cloacal anomaly as that sir has been talking so far, which anatomy he has very beautifully described so far. Single opening in the perineum, which will be draining the entire thing. Out of the academic interest, I have just added this photo. Can anyone name what it is?
Cloacal extrophy.
Cloacal extrophy, typical cloacal extrophy, where the entire bladder is laid open like an open book with the bowel loops in between and the genitalia is played open. Right here, we usually do a colostomy and then go for bladder closure as a staged procedure, and then reconstruction of the anus subsequently. Unlike these things, there are some conditions where antenatal diagnosis definitely makes a very big difference. One among the thing is esophageal atresia. As Jayaraman sir was saying, every drop of milk or every saliva that the papa swallows goes directly into the lungs and causes severe aspiration. These are the children who need to be identified at the earliest, and if they are taken up for surgery at the earliest, they do very well without much of complications. So antenatal diagnosis definitely plays a very big role. This is just to show, this is the proximal segment. This is the distal segment that is mobilized and anastomosed. This is the azygos vein that is divided, that forms the landmark for the tracheoesophageal fistula. And this is the tracheal fistula that is closed. Ideally, we like to have this anastomosis, where both the loops are of equal caliber. Whereas in missed cases, usually the proximal loop will be very big, causing a significant shouldering, and thereby stricture formation is very common of late. So early diagnosis definitely makes a very big difference with tracheoesophageal fistula. And coming to the single bubble appearance into the abdomen, the various differential diagnosis starts with duodenal atresia. Sir has shown a beautiful video. This is the stomach duodenum. This is obstructed segment which is being bypassed. And one thing that we always need to differentiate whenever there is a suspicion of duodenal atresia is malrotation with valvulus. Because duodenal web, annular pancreas, duodenal atresias, all these things can wait for 4 to 5 days. Whereas malrotation, if it goes for valvulus, the entire bowel will be gone. This is a classical bouquet-like presentation of the small bowel with the duodenojejunal flexure lying over here and the ileocecal junction here, and there is a valvulus over here with entire loops being kinked with edematous short, very short mesentery. And this is where the valvulus goes in, typical valvulus. The reason why we take them up without any investigations is sometimes the entire bowel may go for gangrene. Just like what we are doing, we may have to just sit and watch. Nothing much can be done and it is very fatal. So any malrotation, which is indicated by a scaphoid abdomen with a bilious vomiting, with paucity of gas shadows in X-ray, we need not wait for anything and just straight away open them to save the life of the child. And coming to ileal atresias, and one point that I again want to stress, passage of meconium does not rule out ileal atresia. Because unlike duodenal atresia, which is developmental, where it's because of failure of recanalization of duodenum, this ileal atresia is because of a late vascular accident that happens usually in the late second or third trimester. Whatever meconium has gone beyond the atretic segment can be drained during the initial hours of life, right? So again, what Jayaraman sir has showed, this is the various types of atresia where the lumen is intact with intact mesentery. Here the mesentery is intact with widely spread lumen, and here even the mesentery is missing. This is multiple atresias which has got a very bad prognosis because most of the segments we may be losing. We'll try to do as many anastomosis as possible. The chances of leak, chances of necrosis and non-functioning segments are very common, and the classical apple peel appearance with a necrotic bowel. So sometimes even atresia can be hidden. This is a doctor's relative. The child presented with a hernia of the umbilical cord. A nicely formed umbilical cuff is there with the hernia of the umbilical cord. When this child was opened up for surgery, we had a classical multiple atresias within the segment which had to be resected. This is the ideal anastomosis that we want to have. Though there will be a disparity, we want it to be very minimal. Once the child is started on feeds and left over for a few days, the proximal segment will be grossly dilated like this one. This is like a container in a lorry which was fully loaded, and that can be easily seen in the X-ray also. Here doing an anastomosis is very difficult actually. This is the proximal segment and this is the small segment. These are the places where we really appreciate the antenatal diagnosis, where such a dilatation won't be there and we may not be losing a significant segment of the bowel. And another complication that can happen is perforation in late cases, which will also be very lethal and fatal. Meconium ileus is one condition that we need to differentiate from all the other types of intestinal obstruction. The presentation will almost be the same. Behaves like a ileal atresia with a grossly distended abdomen with bilious vomiting. The only thing is in X-ray abdomen erect will not be having the typical air fluid levels, rather a homogeneous opacification in the right iliac fossa. There is Newhausen's sign. And another hint that is commonly present will be the only condition where the distension will be present from birth will be meconium ileus. Usually this is managed conservatively nowadays with gastrographin enemas and oral gastrographin, and only when it does not respond to those things or when perforation happens, we go for surgery. And coming to the last part, that is the anorectal region. The common condition that we see is a meconium plug. These children present on day 2, day 3 with gross abdominal distension without passage of meconium. A thorough wash through the rectum usually empties a long plug, and this can be a differential diagnosis for so many things, starting from hypothyroidism, child of a diabetic mother, short colon syndrome, and even a Hirschsprung's disease. But most of them are idiopathic, which usually responds well. But whenever this child presents with further constipation, we have to think of Hirschsprung's and other things. This is yet another case where a long meconium plug was drained. And coming to Hirschsprung's, I'm not going into the depth of it, just to show what we see in X-rays. This is the proximal grossly dilated segment, and this is the coning, and this is the transition zone to the narrow segment. We usually go for a ileostomy. I don't want to take much of a time after a long presentation. Just to highlight whatever the things that we get to see, I thought I made a small presentation.
That was excellent. Excellent, Vijayarand.
Thank you, sir.
It was amazing.
I thought an elaborate presentation may not be interesting for the radiologist. I just thought a photo album like.
It will be interesting more for the pediatric surgeons, and we may be actually novice in pediatric surgery. Okay.
Sir, I have a question to Vijayanand, sir. Sir, can Hirschsprung's disease present antenatally, sir? Or is it only a postnatal diagnosis?
Usually it is a postnatal diagnosis. Only when the bowel starts functioning, the transition zone and all those things come in, sir. At birth, they'll be usually having a normal caliber bowel loops. Only as the child starts moving the bowel loops, the distension starts setting in and we'll be able to make out the transition zones. So probably I think it cannot be identified antenatally, sir.
Okay, sir.
The same question that the parents will ask after 1 or 2 weeks of treatment, why was it not diagnosed antenatally? The thing that we usually say is even after birth, we will not be able to diagnose without treating the child for a week or so with all the conservative care. So practically there's no chance it can be identified antenatally. That's what we tell the parents. They'll be very anxious at that time.
But usually when there are multiple dilated bowel loops, one of the differential diagnoses which is entertained antenatally is Hirschsprung's, apart from the ileal atresia. Isn't it, Jayaraman? Jayaraman, isn't it what you showed? Jayaraman, are you there? You can unmute. Jayaraman?
Yes, sir. Yes, sir.
As per your some of the slides, you showed a differential diagnosis, Hirschsprung's also.
No, sir, I never see a case of Hirschsprung in a fetus, sir.
Yes.
Only postnatal we have seen cases. I have never seen a case, sir.
Okay. So what is your experience, Dr. Sumati?
Sir, not seen a case yet, sir.
Not diagnosed yet.
And I don't think there are any specific signs also to suspect it on antenatal imaging.
But usually the textbook.
Actually, we had a few cases where we had a doubt, like the rectum was filled with meconium, but the anal canal was always empty, but we could see the continuity of the bowel loops. So initially we didn't know what was the significance, but I think 2 or 3 cases like that, but PMC was normal. So we followed them up postnatally and all of them had a normal bowel, sir. So that was the only thing we came across. We were thinking whether it could be some Hirschsprungs or something, but when we could demonstrate the continuity of the bowel loops, all the babies turned out to be normal postnatally.
Even after birth with ultrasounds and simple x-rays, we may not be able to identify Hirschsprung. Only with barium minima or rectal biopsy, we may be able to demonstrate. Probably antenatally, we may not be able to identify, differentiate it.
We cannot specify the diagnosis of Hirschsprung's
But
antenatal.
have a suspicion.
Yeah, we can have a suspicion, but with multiple dilated bowel loops, that's one of the differential diagnoses which is usually quoted in the textbooks. Okay, and there is some more questions also. Megacystis microcolon intestinal hyperperistalsis syndrome. What he has just mentioned that what he wants to know about it, I don't know.
One of the differential diagnoses for Hirschsprung, very difficult to treat. That's all.
It's usually present in the female. Any more questions in the chat box? I think there are a lot of accolades for pediatric surgeons. Excellent presentation for Vijay Anand. The 5 new questions. Let us see. All of them were only appreciations from the participants. So if there are no more questions, I thank profusely all the participants, but particularly Dr. Vijay Anand, who has spared his valuable time. He is a very, very busy pediatric surgeon at Madurai. He'll be called in almost all the hospitals, and he has spared his time for nearly 1.5 hours and sat with us at this weekend. So we thank you, Vijay Anand, for your
Thanks a lot.
participation.
Thank you,
Dr.
sir.
Sumati and Dr. Jayaraman and Dr. Ravinder Kashyap, who joined
Thank
from
you, sir.
Coimbatore. In spite of Ravinder had a function today, he has attended the function and joined lately. So thank you all very much. It was a very excellent evening with all the knowledgeable people joining together and they're delivering their knowledge to the participants. Thank you all very much.
Thank you, sir.
Have a nice weekend.
Thank you, sir.
Thanks.
Okay.